Good afternoon. Today I'm going to tell you about the Addiction Technology Transfer Center and Opioid Response Network's training and technical assistance work related to integrating hepatitis C services into opioid treatment programs. Early on in our work, we met a man named Riley. He was a client at Athens Clinic, an OTP in Georgia, and had lived with hepatitis C for 20 years. He described his experience attempting to receive hepatitis C treatment as an enormous amount of headache and heartache. When his OTP began offering in-house testing and treatment, Riley was first in line. He became the first person cured of HCV at Athens Clinic. Riley is now a certified peer specialist. He says life without HCV is better than he could have even imagined, and his gratitude is bigger than he has words for. Let's rewind back a little bit to 2018. HCV rates were up 71% from only 4 years prior, and a quarter of new infections were attributed to injection drug use. Like Riley, people face numerous barriers to receiving HCV treatment. To reach historically and presently marginalized individuals in need of HCV care, SAMHSA funded ATTC and ORN to develop products focused on integration at publicly funded OTPs. We aligned our work with goals set forth in the Viral Hepatitis National Strategic Plan, including assuring early detection, linkage to care and treatment, as well as integrating programs to address dual epidemics. OTPs are an ideal location to integrate HCV care because they see their patients regularly, can incorporate new processes into routine intake procedures, and often have on-site medical staff and care navigators. At the onset of our work, we convened experts in the field from governmental agencies like SAMHSA, CDC, NIH, and OIDP, as well as researchers, frontline workers, and people with lived experience. We also visited 5 OTPs across the country that were providing a range of testing and treatment services. The thought leader panel and site visits informed the framework around which we designed our products. OTPs have varying levels of financial and human resources. This continuum illustrates that integration is not an all or nothing approach. Any level of integration is better than completely siloed services. And it is okay to start small. Allie McCorkle, director of Athens Clinic, described their integration as starting as an itty-bitty idea to reduce barriers to HCV care that blossomed into offering on-site treatment. To help others do the same, we developed your guide to integrating HCV services into opioid treatment programs and launched it on World Hepatitis Day 2020. The guide includes a step-by-step implementation plan to walk OTPs through the process. To ensure the guide was more than just a product on our website, we launched a learning community and recruited interprofessional OTPs from across the country to participate. Each OTP developed an individualized action plan based on their organization's goals and capacity for integration. Some aimed to initiate on-site treatment, while others strove to begin universal antibody testing for all new intakes. Between our 2 cohorts, 24 organizations across 13 states participated. Each OTP collected and shared data related to their progress throughout the learning community. After accounting for attrition and challenges with data collection, we had baseline and final HCV testing data from 15 OTPs. Of those, 10 increased the number of antibody tests conducted. To see this level of change on a broader scale, we needed to augment our efforts. We developed a facilitator's toolkit to support replication of this model in communities across the US. And last month, right here in Kansas City, we hosted a 2-day training of facilitators. Although the training focused on implementing this HCV and OTP's learning community, the model can be modified to address other public health challenges or for use in other settings. Addressing substance use disorders and infectious disease syndemically can truly change and even save people's lives. When asked what it meant to be cured of HCV, Riley said, "I now have the luxury of dying of old age. That's incredible. Thank you.
Hit it. Today we're going to discuss reproductive harm reduction. So first, we need to know, I get a title slide. Hi everybody, I'm Joelle. I'm a person who uses drugs. I'm also a nurse, and I've been researching this topic for about 15 years. Awesome, extra time. So today we're going to discuss reproductive harm reduction. We need to know what are the harms that we're trying to reduce or eliminate, how can we think about harm reduction and the people that we serve, and also how can we actually do harm reduction. I'm one of the co-founders of the Academy of Perinatal Harm Reduction. Our mission is to improve the lives of pregnant and parenting people who use substances, as defined by them. Because we want to live in a world where all families are safe, intact, and informed, regardless of what they put in their bodies. The Pregnancy and Substance Use Toolkit is a free digital resource that's available in English, Spanish, and Myanmar. It covers 6 classes of commonly used substances, as well as prenatal care, pain control, birth plans, and navigating the legal system. The most important part of any harm reduction framework is respecting people who use drugs. The intersections of sex, gender, and drug use mean that many women who are already sexualized and infantilized are further discredited and assumed to be incapable of making decisions for themselves, their children, and their families. We might not even see this disrespect in our own practice because our society has so normalized it that we expect the right to bodily autonomy to depend on who you are and what you put in your body, especially when that's illicit drugs or sperm. The next item in the harm reduction definition is improving the quality of life for people who use drugs. The part where a lot of folks get hung up is that this is excuse me, this is really hard to do this. The part where a lot of folks get hung up is remembering it's improved quality of life as defined by them, not us. Finally, I want to talk a little bit about promoting joy and pleasure. Often when we talk about harm reduction, we want to focus on the harms and the risks. But it's really important to look at the whole picture. People use drugs because they work, at least at first. If we ignore the positive benefits that people are getting from substance use, we won't be able to offer new coping mechanisms and interventions to fill that need. Harm reduction can be summed up as positive change. It can be safer use, reduced use, abstinence, or something not directly related to substance use. Change is hard, and celebrating the small victories builds the self-esteem needed to tackle bigger challenges. We mean any positive change. That means if your patient is still getting hammered every night, but now they're getting a babysitter and a designated driver, that's fantastic. Celebrate. When I'm thinking about the harms faced by pregnant people who use substances, I'm not really thinking about substance use, but rather the context in which substance use happens. We face increased risk from lack of access to healthcare, food deserts, poverty. Risk from exposure to environmental contamination increases during pregnancy and is amplified by racist practices, such as those that caused the water crisis in Flint, Michigan, and then failed to correct it for 5 years. We lack access to birth control or experience forced and coerced sterilization. Social isolation, housing insecurity, and the cognitive effects of being told over and over that we're useless, disgusting, and nobody would care if we died. It should be obvious that criminalization and surveillance are not health care. And I'm not just talking about cops and judges and courts. All pregnancy-capable people in this country have to face constant attacks on our reproductive autonomy, as well as intense scrutiny and judgment of our bodies and our choices by the very people that we're supposed to be able to go to for help. This flow chart, I don't have much time. This flow chart can help you conceptualize how to do harm reduction in your practice. We offer 4 pathways: abstinence, safer use, reduced use, or something unrelated to substance use. For example, a patient might need to get dental care, learn to inject herself safely, and make a plan to cut down or stop using. The end goal is any positive change. Again, the most important thing to remember is to prioritize the patient's goals, values, and timelines. When designing programs, policies, and interventions, we're thinking about the harms we talked about a couple slides ago. Most people need their immediate needs met before they can focus on substance use. It can be really difficult to make a change in your behavior if you're hungry, you don't have a safe place to sleep, or you can't physically get to the service location. Some parents may benefit from training opportunities, but these should never be mandatory to receive care or services. Just like all interventions, they should be part of a comprehensive menu of patient-centered, individualized care. Doulas experienced in caring for people with substance use disorder make a huge difference in outcomes and reduce the risk and impact of medical abuse and neglect. These abuses are unethical and often illegal, but they're also extremely common. Many women who use drugs have told me they would rather die than seek medical care. Infants and children in the family court system have the right to a public defender, and parents don't. Lack of access to legal support increases rates of state kidnapping of children and disproportionately affect Indigenous and Black families. Thanks.
Okay, in the words of Shania, let's go, girls. So I'm going to talk to you a little bit about the Indigenous HIV/AIDS strategy, which combined other national strategies, but there's also a QR code that's going to come up after this. So if you want to pull up this national strategy, just to have it with you, prepare yourself. You only have 15 seconds. But this strategy came about because working with our Indigenous communities, we found that a holistic approach comes about in every aspect of work that we do. So when we're looking at the national strategies, we're going to these communities, working with them to build plans and different pieces. And what came from that was that we were having to find every single different strategy and the funding source that related, and that wasn't the focus of the community. So at the end of it, working with some amazing people from across the country, we were able to form the Syndemic strategy that not only takes the vision of the community, but then also makes it a tool that combines all the other strategies so that indicators, the objectives, are all hit out of one document so that it can be used. So this is going to be a quick overview. We are first going to look at sovereignty. Sovereignty is one of the main points of this document and how that has been, especially in some of the areas that we are regionally in right now, have been under quite a bit of onslaught. And so sovereignty falls and hits all of these core values that you are seeing here. And from that also are the strategies that came out of that and the different levels. Whether we're talking about direct patient care, we're talking about the public health aspect, being out in the community, deconstructing the walls of the clinic so that there's access. When we're talking about the pieces of hiring staff that may not have that four-year degree, but guess what? They're going to be able to reach the community better. So now we're going to get into this. Sovereignty. When we talk about this, it's making sure that there's recognition not only from the local areas that our communities are in, but the state, the federal side, the recognition and the respect of the sovereignty, not only for the community, but also for the programs. In the cultural responsiveness, we're talking about the idea that these providers, these practitioners, individuals that are caring for the people may not come from the community. So making sure the culture of humility is there, and that also that the traditions and culture can also be medicine. In the partnership, we see that we not only need to make more collaboration between the Indigenous communities in their work, but then also with those other stakeholders within the public and the private sector. With the awareness and stigma, we all have hit on awareness and stigma today, but making sure that we're identifying our 2S LGBTQ plus incarcerated persons that use substances, and making them recognized in this strategy. The clinical resources and services is mainly about building that capacity, making sure that individuals that work within the systems are being used to their full capacity, people that may not have the licenses but reach the community more. Within the data systems, I asked a question earlier about data access. We have to make sure that American Indian Alaska Native data is representative in the sources that we have to use for these funding opportunities. The indicators that are said here is tables and charts within the document that are going to be used to keep track of progress and other pivots that might take place so that they can be brought back to the table and discussed, because that's how we build our community workforce. Programs and practices is a list of all the different resources that we have currently within the Indigenous communities for good data sources, and well as current best practices and promising practices. The tables that you're seeing now are what we have been able to cross-sectionally add so that each of the objectives that were listed there hit all the strategies and objectives of the national strategies: viral hepatitis, HIV/AIDS, and STI. So that funding sources, federal or state, you can use this document, communities can use this document, and that they will be able to hit all those so that they're not marked against because they're not following within boundaries of the strategies. Indian Country Echo is where this document is housed and houses all the other resources that our communities use when related to capacity building. Quick reference, if you don't come to the session afterwards, these are some of the other great people that were a part of this work that brought this to the rest of the country out of our work group. Thanks.
Okay, if a Chicana who's a self-proclaimed high-context communicator could get through this in 5 minutes, we're winning, okay? All right, get started. Maxine Henry here to talk to you all about a Project Echo that we currently have going on. We're piloting it right now. Actually, about 45 minutes ago, our colleagues just finished our 7th of 12 sessions. So perfect timing to be talking about substance use coercion. This is a partnership between the ATTC Network Coordinating Office, the Region 8 Mountain Plains ATTC, shout out to Cindy in the audience, and the National Center on Domestic Violence, Trauma, and Mental Health. Because we are piloting this in Colorado, we are also partnering with Violence Free Colorado. Substance use coercion is the intentional, deliberate introduction or forced increase of substances in order to cause harm and to have control over other people. It's important for us to know that these have intersecting accelerators. One piece, domestic violence, intimate partner violence, definitely accelerates substance use, makes recovery, abstinence, harm reduction a little bit harder for the person experiencing substance use coercion. As you can see here, somebody who is victimized by a partner sees a huge increase in mental health challenges, suicide attempts, and also substance uses and substance use disorders. On the flip side of that spectrum, individuals who are accessing substance use disorder have reported up to 90%, up to 90% of them have reported domestic violence instances in their lifetime. On top of that, a recent study has shown that a quarter of individuals who have called the domestic violence hotline have said that they have either used substances to dull the harm that is inflicted upon them or have been forced to use substances. True partnership, true collaboration, true systemic change comes with having people with lived and living experience in the room. From planning, as participants, subject matter experts, we need them at every single step. So as many of our colleagues, we have decided to use a Project Echo format in order to train providers working with people with these living experiences in the state of Colorado. And we did that because Echo, through interactive learning, peer-to-peer learning, and collaborative problem solving, really creates an all-teach, all-learn environment. So we're constantly learning from each other. It is important to note that individuals who do cause harm on other people also need access to care. However, we were very intentional to make sure that our focus this time was on people who are experiencing these intersecting harms. We wanted to create that sacred space for them. Now, if you're gonna come and learn at a 12-week series, you need organizational support. We oftentimes are working with people who are underemployed, underpaid, and so as part of the application process, we ensured that organizational leadership signed on to make sure that they committed to the consistent learning. These individuals are professionals. They know what they're doing. Do they need us? Maybe not, but we're conveners. Our goal is to help them hone their skills, to learn from each other, and to do that by teaching each other. And that's how we truly break down silos and we build bridges between these communities, these providers, and these agencies. Many of the folks who are experiencing these are experiencing them at the same time. They don't always have access to all of these services at the same time, or don't know where to find them. So while we're honing their skills, and because they're learning from each other, we're also hoping that they can better teach folks how to navigate the system that they have access to, which of course in turn leads to us aligning with SAMHSA's 8 dimensions of wellness. When individuals get to work on each part of their selves, their family, their person, at a pace that makes sense for them, they're more likely to see long-term positive results. Trauma-informed care is not just a box that we have checked through this entire series. We are very careful and very intentional with every single piece to ensure that the providers who are doing this work don't accidentally step on landmines and inadvertently harm people who are already experiencing it. Of course, language matters, so every single thing we do, again, we have intentional language. We speak with respect and dignity. Safety has been a cornerstone of the entire project. At every single level, we talk about what is going to be the safest thing for the person reaching out to you for help. Is abstinence always safe? No. Is harm reduction always safe? No. So what can we do to make sure they have the dignity to survive? So we hope to see you in the breakout session. We stand ready to take this beyond Colorado. I live in Colorado, love doing this in Colorado, but we'd love to see it across the nation. A little over 5 minutes. Thank you.
Another round of thanks for all our presenters.
Hello, everyone. We're going to get started. Glad to see that everybody is enjoying coffee and conversation, bright and early. I don't know, Nick. I'm going to have to coach you about command of voice. I'm just joking. It's a Latina mom thing, I think. My boys know, like, the moment she starts rattling off in Spanish, everyone's in trouble. So, bienvenidos, buenos dias, good morning, welcome. We're so excited to have you all back on day 2. Y'all probably remember my name from yesterday, and it's up on the screen, Maxine Henry. I'm with the Collaborative to Advance Health Services. We want to say thanks for coming back to day 2. We have a half day, and so we'll release you right at the pinnacle of the heat of the day. So maybe next time we'll do, 2 full days, so that way we can have a little bit of relief from the heat. We just have a couple of announcements and reminders for all of you. First of all, the opinions discussed during the summit presentations are those of the speakers, and they do not necessarily reflect the official stance of the Collaborative or the University of Missouri, Kansas City. There are still materials on the Take One table over by where y'all signed in yesterday or today if you signed in for the first day. So please feel free to keep any of the items of interest for you. In your program booklet, you are going to find a QR code that's going to link you to the summit evaluation forms. So our colleague will remind you at the end of today, but I know some folks have to leave a little early. Again, we want to apologize in advance. It might seem a bit repetitive and you might get asked similar questions more than once, but our evaluations really do help us do quality improvement. We really do look at these evaluations, we do learn from them, and it's also how we get funding and keep our funding. So we would truly appreciate it if you all would take a few moments of your precious time and fill out these evaluations for us. I do want to thank the Advisory Council for this summit, for all of the hard work, all of the outreach, all of the invitations that you all have done for us, and also the engagement that you have done while you've been here. We could not have done this without our collaborative staff. Every single one of you have just done an incredible job this entire time. So the 6 months leading up to this, when we talk about it in a couple weeks, I think everybody will just be very proud of themselves. We would be remiss to also, if we didn't thank the Kaufman staff, the food, the service. Thank you. This is such a beautiful place, and we're really excited to have been able to do this. Maybe when we do this next year, it won't be as hot. Everyone can visit the gardens next door. But thank you to the Kaufman staff. One more thing, at the beginning of the first break, if all of the A and PTTC folks would be willing to please come up to the stage, we'd like to take a picture. We very rarely get a chance to all be in the same place at the same time, so that would be great. So we'll see you for the photo, but I'm gonna hand it over to my colleague Nick Zhubiak, who will be kicking us off for the day.
Thanks, Maxine. Good morning, everyone, and again, welcome back. I want to invite up to the stage for Showcase 2, our regional state syndemic approaches in action, highlight of projects, and work underway in states and regions. So if Laura, Precious, and Sharon could make their way up. Hi, Precious. Take your time, take your time. So we're going to start with some introductions, but someone that needs no introduction, but we honor her with one. Oh, do you want to say hi?
Serial, Aton Barasuenimo.
Okay, great. Welcome. Come on up. That's great. So we're going to go ahead and start with some introductions. Laura Guzman has been acting executive director of the National Harm Reduction Coalition since January of 2023. After joining NHRC in 2020 as senior director of capacity building and community mobilization. She's a human rights activist and a nonprofit leader with 30 years of experience serving, building capacity, and organizing across communities in the interest of harm reduction. And our second speaker, Precious Lefevre, is the Harm Reduction Coordinator for Sexual Health and Harm Reduction Services at the Oklahoma State Department of Health, serving Oklahoma's most vulnerable populations. Through her work, Precious has firsthand experience of how important applying a syndemic approach to public health issues is to close the gap in health disparities in her region. And our third panelist, Sharon Hesseltine, is president and CEO of Intentional Development, providing consultation, facilitation, and training to strengthen services for pregnant and parenting families with substance use disorders, adverse childhood experiences, and trauma. Sharon has worked in public health for over 35 years and specializes in early childhood development, women's health, substance use disorders, and recovery. She's passionate about developing the capacity of communities, organizations, and individuals to meet the needs of those with substance use disorders. She's also an advanced implementation specialist for the Opioid Response Network. So we're gonna go ahead and kick our panel off. We'll ask Laura maybe to lead us off, and each panelist is gonna take about 15 minutes. And then we're gonna do our best to open it up for some Q&A. You want the move over here? You want, which thingy? Oh, yeah. And maybe someone from our AV could give us the clicker for the slides. And let's see if, I'm afraid to press this button, but let's see what happens. Okay, there we go. There you go, you got it. All right, thank you, we got it. Big green button.
Good morning. I'm gonna have to multitask. This is complicated.
Do you want this? You want this?
Nah. Now can you hear me? Yeah. So it's a real pleasure today to share with you, and I think it was kind of like very inspirational when I was in the, I guess the advisory to the summit, and this idea of how do we present, you know, some examples at the local state level on end epidemics, and you're gonna see it's kind of a creative approach to the end epidemics that we've been doing in California, because in some ways, we've been doing community mobilization with the End Epidemics Coalition towards the end of you're gonna see our trajectory, but also our syringe service programs in California due to the fighting for funding and actually doing an amazing work that just resulted in $61 million we got for our second initiative for 4 years. From opioid settlement funding, we thought it was going to be a really good way to show end the epidemic. So I call it a California community mobilization and syndemic approach to funding services and improving health outcomes for people who use drugs. And I wanted to make sure that we talked about both. I think most of you know who we are, but we are a national organization, the oldest harm reduction organization in the country that creates spaces for dialogue and action that help heal the harms caused by racialized drug policies. And we are presenting today, and I'm presenting today with this concept we've been kind of running around, is that harm reduction and harm reduction programs are key to a syndemic approach. And so I start with a slide. By the way, all this awesome photography came from an action we did on May 15th that convinced Gavin Newsom that he had to give us $61 million. But they're all the amazing work of Brooke Anderson, who is a movement photographer. So you'll see beautiful pictures of us. And Edith Springer, how many of you have ever heard of or know Edith Springer? Some of us in the harm reduction movement, she was one of our pioneers, social worker who used heroin. She was my mentor when I became a trainer. And she had this phrase, among many other ones that are funny as hell, but harm reduction is loving people back to health. And I wanted to start our presentation with this today. I also wanted to show, not to go through, the fact that, you know, when we talk about harm reduction, what are we talking about? Because there is harm reduction as the definition of what it is, and for us it's not only a philosophical, a set of principles, practice and movement, but we also want to talk that there is harm reduction services that are very specific and very relevant to end epidemics, but also the fact that what we're talking here is about the application of harm reduction as a framework for this syndemic approach. And we'll talk more in a second about why. Just again, to show that for us it's a continuum, and this is to debate anybody who alleges that we're not about abstinence, because that makes me really mad. A lot of our folks in the movement might be, you know, they define themselves as abstinent, but a lot of our folks in our movement are also people who use drugs. And so I want to make sure that we understand we do have the continuum, and we believe in the continuum. And then some of the things I talked at least, and we talked together yesterday, right? Racism, stigma, and criminalization cause harm, and we need to make sure that we say it as we do this work. Leadership of the most impacted is key to transformative change. And then ending inequality and oppression, fostering health and liberation. That's our mantra. We say we're about love and we're about liberation. And then harm reduction services, and they keep evolving. So I'll tell you my latest involvement with seeing drug testing machine in San Francisco run by the AIDS Foundation. A mobile van with a drug testing machine helping people determine, is this fentanyl or not? Does it have psilocybin or not? You cannot tell how much or how good is the drugs, but you can tell, the people can tell what is on it. And so drug testing things is one thing we really are starting to support and sponsor throughout California and other places. And then the need for harm reduction. I don't think I have to argue in this room, but I think we need to do this everywhere. We respond to disproportionate disease and fatality rates. We reach vulnerable populations, and we keep individuals engaged if they relapse or are not abstinent from drugs or sex. And this is very important. You know, I think we always say we meet people where they're at. We also don't leave them there. So we're always accompanying people. I'm not gonna go to any of this data. I think science supports harm reduction. CDC said it. I don't have to say it, right? Once you get the feds to say it, okay, we're in a good place. So I'm not gonna go to any of this. Couple of things in this slide. We saw an impact of reduction in HIV and HCV. We still have huge OD rates. Yesterday I heard doctor from Buffalo, I don't know if he's here, he's amazing by the way, talking about the rates of HCV in young adults who inject drugs is actually on the rise. In part because we may not have done a good job yet of reaching that population, and they're not that familiar with some of the, clean needles, don't reuse needles, etc. messages. We also have the impact of fentanyl and now silencing in the drug supply. Criminalization is the result of having this very unstable drug supply, and we need to say it. It's not people's fault, because that is what, we end up actually, arresting people who use fentanyl rather than really, addressing the real causation. We see a movement in the federal government. I was very pleased to hear some of the presentations yesterday. Extremely pleased as someone who's been doing this work for 30 years, but there is so much more work the federal government has to do. And then just knowing that when you present this to legislators, and we've been doing work in other weird states, you guys, but in Kentucky, we had someone say, when I saw the research, harm reduction was a no-brainer for me. So this importance of keep using the, I call it now, rights-based, science-based evidence. I'm not gonna go to that because there were better, in terms of money, it was better presentations these days. I wanted to really emphasize the benefits of resource and syringe service programs, because this is what we did in California. Leadership and meaningful involvement of people who use drugs. Many of our SSPs, by the way, when I started in 2020 at NHRC, we had 69 authorized syringe service programs. California is hella big, you guys, right? But we had 69, we now have 80. 3 years later, as a result of the work that we've been doing in supporting SSPs, whether we had funding or not, and also the partnership with the California Department of Public Health Office of AIDS. So you see some of this. I just want to mention, many of the things of a syndemic approach that are critical, right? Access to medical care, HIV, Hep C services. Many of our SSPs are also AIDS service providers. Oh, they might have been engaged in doing Hep treatment. Okay, he's giving me the 5. I'm gonna move. So I wanted to say that the California experience has been amazing, and when we fight, we win is the logo and the motto of the California Syringe Exchange programs. And we also created this amazing, you're gonna see some of our wares. And I wanna say that it started sometime in 2017, 2018, where we went, the Harm Reduction Coalition, Drug Policy Alliance, the California Department of Public Health, although they cannot advocate or lobby, right? But they were supporting us, and the KSIP organizing group. We went for a budget win. We fought in the legislation for 2 years, and in 2019, by the way, you're gonna get the slides. You should go to our core budget win. Savannah O'Neill, who is here, is one of the producers, and we did a whole timeline to show that our syringe service programs were itching for funding because of some of the federal cuts to HIV prevention to people who use drugs. It's like we go in this circle, so what doesn't make sense gets done. And this is some of the beautiful people that not only fought for, but also members of KSIP early on. And so I want us to say that we've been developing this coalition now for 5 years strong, and it is a mutual aid and advocacy network of syringe service providers and programs that we work collectively to build strong harm reduction programs and organize to reduce the harms of the racialized war on drugs and drug use. So we are doing both. I have some cute pictures of cute people. Some of them, from organizations. We started the first conference in 2017. We had it in 2019 and remote in 2021. Look at the fashion, you guys. You have LA and Oakland, okay? We're famous for wacky, awesome fashion. And this is the team. This is my team, I have to show. This is the people that supported the initiative and every other SSP, whether or not it was funded or not. And so we got $14 million in 2019. That was how we started the first initiative, and we ended up grant making, funding, doing training, TA, and evaluation with 37 syringe service programs throughout California. I just want to read this from my former boss and friend, Monique Tula, who was our ED, because this is key to what we're talking about. Ending HIV, hepatitis, and overdoses among people who use drugs won't happen without sustainable funding. In one of the defining crises of our time, public officials in other states must demonstrate the same commitment for expanding harm reduction programs because lives depends on it. So I could do a whole presentation on Chile, right, Savannah? We can spend a whole day, but was the single and first largest investment in California until we got the 61 million. And you saw, I was talking about point-in-time counts. You can see the range. Those of you who love GIS mapping, we have an amazing evaluator who's both a drug user and a researcher and has been doing GIS mapping for us. We have polled unique 2,000 participants of SSPs during the 3 years, and some of the data is in the slide, which you're gonna see. And there's some slides about how people perceive MOUD. We also been tracking demographics, which most SSPs don't do because it's labor intensive. We have drug use data. That's how we discovered that people were smoking fentanyl and not injecting. And now after 2 years, you start seeing the spread of smoking versus injecting. And this came from people in the field, from people with living experience telling us what's going on. We didn't need researchers for that. And just a couple of impacts, because I think it's important. Thank you. So we serve 135, when we find SSPs, we were able to serve 135% more programs and distributed 75% more supplies. We gave naloxone to 73 more people and distributed 68 more naloxone doses. We distributed 3 times what the law enforcement people did, even though they got the same amount of Narcan. And that's what we start fighting to say the money should go to people who use drugs and SSPs, not to law enforcement. We also had 85% of those SSPs that offer BUP on site compared to 31% of non-CHERI SSPs. So when you fund an SSP, you're funding treatment as well for those that are willing, ready, and able. And then we collaborated with each other, and that was the most fun. And so I wanted to go through the fact that we kind of also inserted ourselves on the Ends the Epidemic Coalition, a very powerful coalition in California that is also kind of new. And so we inserted overdoses to HIV, STD. We went to say overdoses should be part of the epidemics. And that was thanks to our director of community mobilization that got to be involved. And so we started doing work together. And you can see how much money together KSIP and the Epidemics won. We made $5 million win for HIV, HCV, and STI when there was none. Second year, we got $13 million win, $3 million to expand our clearinghouse. We get free needles, free pipes, and all the supplies. We also got $38 million in 2022 for syphilis and hepatitis B, and we got the $71 million because we got 61 for harm reduction and 10 million for hepatitis C treatment, which we haven't seen in California. Can we get an applause? Do that. So I'm gonna close with some fun pictures of our May 15 action. You can see our lovely people. These are both SSP staff, participants, colleagues, and I leave it with the future Syndemic work. Thank you very much.
Thank you, Laura. So, Precious, I'm just going to ask if it's okay. I'd like to do just a quick introduction. And we talked a lot the last 2 days about sometimes what it takes for clients to get to us. And I'd just like to share that what it took Atanbar to get to us today was quite the travel. I understand you got in at 2 a.m. this morning, and you had a very difficult travel. So we're very grateful that you're here. And I do, through the quick work of my team, have a quick bio, so I'd like to read that if that's okay with you. Great. So here we go. Atambara Sowaimo is from Bayelsa State, Nigeria, and has lived in the U.S. for over 10 years. Atambara is the Administrative Programs Manager of Prevention and Harm Reduction Programs at the Oklahoma State Department of Health. She is responsible for prevention programs related to health education, including Rapid Start, public health detailing, HIV and HCV rapid testing, HIV self-testing programs, harm reduction programs, and outreach. So please join me again in a round of applause for Atambara and Precious. All yours.
Hello? Okay, perfect. I'm gonna stand right over here.
Okay,
I feel
you-
more comfortable behind a
all
podium
yours.
for some reason.
All yours.
Okay, so today I'm gonna be talking about taking the syndemic approach to harm reduction and highlighting harm reduction in Oklahoma. Okay. Okay, we have no disclosures to report. Okay. So by the end of this presentation, you're going to have a brief background on the history of harm reduction in Oklahoma, a few definitions of how we define harm reduction, knowledge of how we're strengthening harm reduction through collaboration efforts, and then lastly, an understanding of a specific syndemics that is affecting people who use drugs in our state. So one of the reasons I'm sharing with you the history of harm reduction in Oklahoma is if you look at a map of SSPs in our region, it's safe to say that we are in a harm reduction desert. And I'm hoping that if there are people in this state where harm reduction programs that have not been legalized yet, maybe some of the efforts that have worked in our state can have the same effect in yours. Oh, thanks, Laura. Okay. So a lot of work has been put into the legalization of harm reduction. It's been a community-driven effort consisting of harm reduction programs, religious-based organizations, community-based organizations, councils, coalitions, and action groups, and among many other key players. So groups like the Oklahoma HIV and Hepatitis Planning Council, the OHHPC, have been active advocates and educators for harm reduction services. So dating as far back as 1997, they have actually been consistently discussing and researching what was then previously referred to as the Needle Exchange Program. And then in my division, Sexual Health and Harm Reduction Services, the previous Viral Hepatitis Coordinator and Administrative Programs Manager for Intervention and Prevention Services, they've worked on educating others around harm reduction. They even proposed an emergency syringe service program for 2 counties in Oklahoma in 2020. And they also wrote a proclamation with the Oklahoma Medical Association addressing the need for harm reduction services in our state. So this is a conversation that's been occurring for a while. And then in 2019, in an effort to take a less stigmatizing and more inclusive approach, my division changed its name from HIV and STD services to what it is now, which is Sexual Health and Harm Reduction Services. So also several people have paved the way for what we have today, which is the legal operation of harm reduction in Oklahoma. This happened with the passing of Senate Bill 511, and this passed with bipartisan support in February of 2021. So this wouldn't have happened without the efforts like the OHHPC and also harm reduction organizations, the Oklahoma Harm Reduction Alliance, OKRA, and then Stop Harm on Tulsa Streets, SHOTS, and they're here right now. So yeah, shout out to them. So SHOTS was a key player in bringing harm reduction services here. They began offering services in 2018, so that was 3 years before the passing of Senate Bill 511. And they really laid the groundwork for harm reduction here. So I'm very proud of SHOTS. Sorry, I'm looking at Hannah right now. So anyways, yeah. So also before the passing of SB 511 in the Senate, OHHPC members called and emailed their representatives and educating them about harm reduction and its benefits. And then after it was passed, they drafted an email to send to Governor Stitt encouraging him to sign it into law. Okay, so Senate Bill 511, what does it mean for programs? Well, it just means that programs can provide harm reduction services legally, but there's 2 stipulations to that. So one, they have to register with the Oklahoma State Department of Health annually. And then they also have to provide aggregate quarterly data reports to OSDH as well. And what has to be included in those reports is on the screen. Now, before I move on to the next topic, I just want to make 2 notes here. That although this bill was passed in 2021, it wasn't until 2022 that sites could actually register with the Department of Health. And this is because the permanent registration rules had not gone into effect until 2022. And then lastly, there is a sunset clause attached to this bill. So it is set to end on July 1st of 2026. But we're hopeful that by that time, we'll have gathered enough data for it to be renewed. I also want to note that there was not any additional funding attached to this bill. So when I heard Laura talk about all the money in California, I was like, oh, I'm so jealous. But also really happy for you. Okay, so what is harm reduction? Well, there's many definitions, but a simple one could be just reducing the risk involved in using drugs. So we try to support this on 2 levels. So on an individual level, this involves meeting people where they are and not where we think they should be. So it's a person-centered approach to care, and it's about addressing what that person wants as opposed to what you think that they might need, because we ultimately know that people are experts of their own lives. And then we also believe harm reduction initiatives should be led by people with lived experience. So this involves creating opportunities for feedback, but when you create those opportunities for feedback from people with lived experience, you need to make sure that you're actually listening and learning from them as well. Okay, so even our journey after the passing of Senate Bill 511 has had some challenges, and we have relied a lot on community members who are doing same or similar work in the field. So a key approach to the Syndemic approach is to integrate services, but how do you integrate services when you are a State Department of Health where efforts and agencies are accustomed to operating in a silo? So community building and the rapport process we found to be an effective approach to breaking down those silos. So a lot of our community building efforts have been through trainings, and then most recently there was a Harm Reduction Council creation this year. So the Association of State and Territorial Health Officials held a boundary-spanning leadership model to strengthen Oklahoma harm reduction programs. And this was really instrumental when we were in the beginning stages of building collaborations and working through barriers. And then the National Alliance of State and Territorial AIDS Directors in April of 2020 held a statewide harm reduction training that was widely advertised and very successful with over 50 participants in attendance. And the goal was to familiarize community members on harm reduction and its benefits. And then this year, we've also begun offering harm reduction trainings, and our goal is to eventually take these to different parts of the state, including rural areas. And then this year, the Harm Reduction Council was created as well, and one of the major benefits of this is that harm reduction stakeholders can come together and really strategize on how to expand harm reduction services throughout the state. And we've also found as state agencies, this is a great opportunity for us to really listen to what harm reduction organizations need and what their participants need. Okay, so another way we approach community building is through our internal and external partners. So some of our internal partners have been the Oklahoma Department of Mental Health and Substance Abuse Services, and then Injury Prevention Services. And then other internal OSDH departments have been the Office of the Assistant Commissioner of Health Preparedness, as well as district nurse managers, and the Administrative Programs Manager for Prevention and Intervention Services. And then community-based organizations, one of our external partners, Hope Tulsa, which they're here as well, they provide services to clients, and they also partner with SHOTS, and this is direct quote, they said that they're BFFs, Hope Tulsa and SHOTS. And they also have Oklahoma's first harm reduction vending machine. So we also partner with other harm reduction organizations to gather feedback on initiatives, and then we partner with tribal bodies similar to the Southern Plains Tribal Health Board. So find your allies in your group is what this slide is meant to say. Okay, so by this point, most of us probably have an understanding of what constitutes as a syndemic. We're going to talk about a specific syndemic that relates to people who use drugs. So HIV, hepatitis C, syphilis, and substance use disorder. Okay, he gave me the 5-minute mark, so I'm going to speed up. So I want to start with this quote, though. So inequities in power, money, and resources give rise to inequities in conditions of daily life, which in turn lead to inequities in health. Okay. So here are some examples of social determinants of health in Oklahoma, and I'm just going to highlight a few. So 1 out of 6 Oklahomans live in poverty. We are number 1 for domestic violence in this nation, and then 1 out of 7 Oklahomans are uninsured. And the reason I'm showing this to you is because social determinants have direct health outcomes on people who use drugs. Okay, so now I'm going to go ahead and let Atambara take over. Sorry, I gave you 5 minutes.
Thank you. Good job, Precious. Thank you. Okay, so I'm gonna go mainly into talking about the Sexual Health and Harm Reduction Service and how we are an integrated service. So we are divided into 4 divisions: prevention and harm reduction, of which I am over, the care delivery division, surveillance and analysis, and intervention, which is where our disease intervention specialists are housed. So why are we talking about a syndemic approach to harm reduction? Why is it important? Why are we here today? You know, we're talking about integrating efforts towards a common goal, right? So we're talking about really the burden of health costs. And I put this here just if you stop 3 HIV infections a year, harm reduction programs essentially pay for themselves. We work at the health department where really numbers and money is what moves people. So if you can show cost savings, then you can show the effectiveness of a program, even though there should be much more to be looked at, you know. But just being smart, picking your battles, and knowing what to really look for and what the legislators and the lawmakers are actually looking for. Most harm reduction programs become one-stop shops for testing, care, and treatment, and just routes to link people to services that are needed. Someone might come into a harm reduction program once and all they need is, they just need equipment. And that's all they come for. They don't want to talk to anyone. Like in Hope, they don't have to talk to anyone. They just really walk in the door. If they just want equipment, they want Narcan, they want whatever, they just go to the vending machine and get it. They don't have to talk to anyone. But then if they want to talk to someone, there's someone there that can engage with them. So very low barrier initiatives and efforts. I'm gonna speed up to more data. So who is mostly affected across the board? We see about 8.2% of HIV cases in 2022 reported in Oklahoma reported injection drug use. About 78% of congenital syphilis cases in 2021 also reported injection drug use. So if you look at this data, you can see that really individuals who inject drugs across the board are affected by HIV, by hepatitis C, by syphilis, believe it or not. So a combination of all of this really just create the perfect storm. Now this is supposed to be a video. I don't know if it'll, oh, there we go. So we can see the progression from 2011 to 2020 of primary and secondary syphilis reported in Oklahoma. So look at how the dark kind of covers our state real quick. Now this graph shows primary and secondary syphilis rates per 100,000 population from 2010 to 2021. Notice in 2017, Oklahoma's rates of primary and secondary syphilis surpasses the nation, 2021, and we keep trending upwards. This is also a graph, so just look at it. This is the United States as a whole, reported congenital syphilis cases, 2011 to 2020. So that's our nation right now. The next graph is specific to Oklahoma congenital syphilis cases, 2011 to 2020. Yeah, so we can see that the blue are counties that have at least one case of congenital syphilis. So some efforts that we have kind of put forward to address congenital syphilis is we've implemented a congenital syphilis review board and a congenital syphilis task force. There has been a passing of Senate Bill 292, which it makes providers test based on CDC recommendations, which is really first and third trimester testing. And then the governor put forward a Help Every Life and Parent initiative. Okay, so HIV and hepatitis C in Oklahoma. This is just really trying to see how these intersect. I think I'm gonna go through that. I don't know if anyone ever talked about Scotts County, Indiana. Yeah, but this really opened a lot of eyes to really what was going on and how HIV and injection drug use kind of intersected. So I just wanted to put that out there. This is specifically Oklahoma hepatitis C cases in 2001. We can see about 67% of cases reported a risk of using injection drugs, so really needles for street drug. And then we did a vulnerability assessment in 2019, and we found out that a lot of HIV and hepatitis C cases in all 77 counties, about 64% of them had were reported injection drug use between 2015 and 2017. So really just to end, harm reduction saves lives. I can't echo enough how much it does. Even just being that door that everyone comes in, there is proven relationships between the rates of HIV, hepatitis C, substance use disorder, and STIs that we need to consider if we're thinking in a more general scope. We can't use a one-size-fits-all approach if we're going to really end these epidemics. We really need to look at what's being done across the board. We need to look at what works in our state and bring the people with lived experiences on board, because they know what is going on within the community and they can help act as well. And then collaborations make the dream work. So thank you all for having us today. Have a good day.
Thank you, and we'll hand it off to Sharon.
All right, is that working? Awesome, awesome. It is really great to be here today. And I have to tell you, so I can settle myself down, being in front of so many people yesterday with that first showcase with the 15-second slide per slide, my first thought was, oh no, I missed an important piece of information. What am I going to do? And those of you who know me, you can imagine the panic, because 15 seconds on a slide is probably something I've never been able to do. So I'm going to talk with you today about a project that I've had just, I think, the great gift of being able to be a part of here in Missouri. I'm actually from Kentucky, but my work gives me opportunities to be a part of really cool things that happen in my state as well as a number of other states. So this really happens, though, within the broader landscape of everything that we have been talking about. And we're really focusing here in this particular project around supporting and strengthening the capacity of peers who provide services to pregnant and parenting people with substance use disorder, as well as opioid use disorder. And so when we think of the broader landscape, and I think about this population, and my background is public health, so we keep using the term maternal and child health and so on, although I think we're probably long overdue for some language changes there. But when we look at the data, and in public health we love data, then what we see is there's such a strong connection, right, between overdose death rates. We look at maternal mortality, particularly Black maternal mortality. Black women are so disproportionately affected when it comes to maternal mortality, as well as infant mortality. I had the opportunity in the last couple of weeks, right, to hear the story from a friend, a Black woman, and her delivery experiences with two different children several years apart, and what she faced in those experiences. And as I listened to her, and my heart really broke, because with her first baby, it resulted in not being able to even remember him being born, not being able to hold him, not having that time with him. And so when I look at data, what I remember is that there is a story and a person and a family, right, behind every data point that we talk about, which is why this work becomes so important and why we have to work across systems and together to do that. The one thing that my bio doesn't always talk about is that I am also a person with lived experience. And I'm a person who has lived experience of what I say of being a parent who is very far removed from the parent I wanted to be in my active addiction, and a parent way beyond what I imagined I would be. And so this work and this project and everything involved in it is about how we support parents in being the parents they want to be able to be. Because there's tremendous pain in looking back over a period of time when you couldn't be there for your children in the way that you wanted to be able to show up. When we look at the broader landscape, we can't ignore the disparities that exist within our child welfare system, and that Black and brown people are far more likely to be referred to, and let's face it, this is not a referral, it is a report, to child welfare systems than white women. And when those reports are made, they are far more likely to have their children removed, to have children in the foster care system, and far less likely to be reunified. And we always have to remember, and I come to this also with a background in infant mental health, is that when there is a disruption in our early relationships, even if it is in our first day earthside, it has a lifelong impact. And so often I run across people who will say, well, with the young children, they won't remember. But they know, right? They know. And those memories are memories we can't change because they're not attached to language and they're held in our body. So these disparities continue and they get passed from generation to generation. So we talk about upstream. I think there's an upstream beyond the work with pregnant people and with children, and upstream and looks at, right, oppression and disparities and inequities that need to be addressed. And at the same time, there are people all over this country today who are pregnant and who are having babies, so we need to support folks and change systems. So for this project, and this project was a partnership between the MidAmerica ATTC, the Missouri Credentialing Board, as well as the Missouri Department of Mental Health. And really the goals are about strengthening programs and services for pregnant and parenting families who have substance use disorder by offering and providing specialized training for peers as well as others who are serving this population. So that includes a pretty wide variety of disciplines and programs and funding streams and so on. And it also is about reducing the stigma specific to pregnant and parenting families with substance use disorder. This is a highly stigmatized group of folks, which I'm sure that everyone here is very well aware of. And they work with and rely on multiple systems and settings to be able to move forward. So the approach for this project was to build a cadre of skilled and knowledgeable trainers, primarily folks with lived experience. So the majority of the trainers are folks who are actively working as certified peer support specialists for the state of Missouri. We leverage the resources of multiple training and technical assistance entities that are really connected through the collaborative. And I think this project is such a wonderful, wonderful example of what we can do when we pull together resources all the way through the system, right? And so we're building on, right, collaborative relationships to maximize resources. Because I'm a person with infant mental health background, what I fully recognize is none of this happens without relationships, period. It just doesn't. And we also want to look at how we provide ongoing support for the trainers. So this started with a curriculum that is titled Providing Peer-Based Recovery Support Services to Pregnant and Parenting Families. And I had the honor to be asked to write this curriculum, like professional bucket list kind of stuff that you never imagine is going to happen, through the Opioid Response Network. So I want to make sure that folks know that this curriculum and this training and the opportunity to train others as trainers and build capacity across states and community is available for anybody through the Opioid Response Network. And so we have, right, these entities really coming together, and what we did was a week after Thanksgiving, and November 2022, we brought together folks for the 2-day training with the curriculum, followed by a 2-day training of trainers. Not everybody who attended the training stayed for the training of trainers. There's a small and select group of folks as the training of trainers, but everybody who became a trainer went through the training. It's exceedingly difficult to train something, right, that you've never experienced as a participant. And so, right, each of the different, right, organizations or entities involved, this all contributed. So Opioid Response Network, that was the funder for the training and for the development of the curriculum and for the development of the training of trainers, the development of a fully notated trainer manual. So that whole package for training and training was through the Opioid Response Network, and as I said, available more widely. MidAmerica ATTC, right, for this event, really kind of initiated this project through a long-standing relationship with the Missouri Credentialing Board and the Missouri Department of Mental Health. So they brought the curriculum. They also brought one of their staff members who had been through actually a previous TOT with us to really provide ongoing support and to recruit and bring in the participants. They covered the travel costs for everybody who attended, made all the logistical arrangements, all the coordination, right? All the great things that we've all experienced for this conference was offered and brought through the MidAmerica ATTC, right? Copied all the materials and so on. And will also support the ongoing support that the trainers will receive, because what we didn't want to do is train a bunch of folks and then say, go forth and train, good luck. Right? There's a lot that comes up in these training experiences. The Missouri Credentialing Board, right, provided endorsement for training participants moving forward. So the whole goal is to build capacity for the state of Missouri to continue to offer the training throughout Missouri. The MCB, their original idea was that they would offer like an additional kind of credential for peers. And after sitting through the training, came to the conclusion that they would rather do an endorsement because this training and content needed to be more widely available across systems, which was really, really wonderful. And they will continue to support both the trainers and the provision of this training across Missouri, and have a number of them scheduled for this year. So they'll do that, right, hosting those ongoing trainings, logistics, marketing, et cetera. And they also have a really close ongoing partnership with the Missouri Department of Mental Health, who also supported this event. They participated in the planning, helped to identify training participants, potential trainers. This was in many ways modeled after the same partnership that they enjoy around the peer certification training for the state of Missouri, as well as training supervisors of peers across Missouri. So this is kind of an ongoing partnership between these organizations. I feel like maybe I missed something. I didn't. That is, wow, that's amazing for me. So over the course of time, one of the things that we will continue to do over this next year is provide, and this is through the MidAmerica ATTC, but again in collaboration, is an ongoing community of practice for the trainers. So I've been training this curriculum for the last several years, and lots comes up in a training where many of the participants are being trained around things that are part of their own lived experience. So supporting trainers, right, to be able to support training participants. The content cuts across public health, prenatal care, family support services, infant mental health, treatment, recovery support. That's a lot of stuff, right? So helping people continue to grow their knowledge base and support is really critically important. So we're going to be working on that through the coming year. Through ORN, folks are able to request training in their states. We've been able to do some work with Texas, who's doing some similar things with their state opioid response dollars. We've been doing some training with Florida, although we are waiting now. After doing this for a year, evidently the curriculum needs to be reviewed at some higher levels of state government. We have done this with the state of Kentucky, where I live. And Laura, I have to tell you, I loved seeing that quote from Van Ingram. I've heard him say that in multiple settings. So it wasn't just one time, he says it all the time, which is wonderful. And we're currently also working with the state of Virginia, really through a partnership there between their Women's Services Coordinator within their Department of Behavioral Health, as well as a nonprofit recovery community organization in Virginia, and we'll be training and then doing ongoing support for a cadre of trainers there as well. So I stayed in my time, right, Eric? Yes.
Thank you, Sharon. And fortunately, the team's worked to create some more time for us to do some Q&A. So we're going to have some mics running, and I want to open it up for a couple of questions or discussion points from the audience. Thanks, Shelby.
Lucy Slater with NACCHO. I just had a quick question about your congenital syphilis data in Oklahoma. Were you able to do any race, ethnicity, demographic overlays to that? And I'm thinking in particular of looking at congenital syphilis rates within Alaskan Native and American Indian communities.
Yes. We've been able to kind of cross-reference. We're going to do that with most of our data. And I will tell you that there is a disproportionate rate within the community. I can't tell you what specific percentages, but there are disproportionately affected.
Thank you.
Melissa Smith from Casey Care. I have a question also for Oklahoma, being in Missouri. The planning group that you mentioned for HIV and hepatitis, was that associated with the Ryan White program, or was that independent? Can you talk a little bit about that?
Yes, so originally our planning groups were kind of siloed from, I say, 15 years back, but there was a realization for the need for them to interact with each other. So we had a hepatitis planning group, we had a care one, we had an HIV one, so it kind of came all together to form the Oklahoma HIV and Hepatitis Planning Council, because then we're able to work more together towards goals that are across the board. We are an AHE-funded state as well, so we're able to really work towards the pillars. We actually have subcommittees that come out of the OHHPC that specifically are working towards each pillar, and then also cluster detection and response committee from that.
Thank you.
Thank you. I think.
Can you hear me? Because I was in, HIV Service Planning Council, I think that question is so important because I was very surprised and loved to see that. But in a lot of HIV, they have become really political with people coming from abroad to above to say what this planning council should do. But I think this Oklahoma example is amazing because that could be, that's where we started to talk about harm reduction in the HIV Service Council back in the 90s, right? And to make harm reduction a priority. But it has divorce. A lot of HIV services have divorce. When I'm looking at the data that we've been looking at the last 2 days, it tells me, oh my God, we're back in 1995, because more than ever, because the data now suggests new seroconversions, Hep C impact is really happening among IDUs primarily. And so this means that we had to have serious conversations in our in the syndemic groups, those that form, what does that mean in terms of what we're seeing, in addition to the racial disparities.
Thank you. And I think we have a question here, and then we had a question over, and actually we're going to go to the question over here. Yeah, please. Thank you.
I have a question for Sharon. My name is Michelle Freyspray, and I work at UNR and under the Prevention Technology Transfer Center for the Pacific Southwest. So Sharon, you mentioned the training in the TOT. Can you go just a little bit into the content that you cover as part of the training? Is it skill building for the parents? Can be interesting just to hear a little bit more about it.
Yeah, absolutely. Thank you. And I'll try and keep it brief. And if you want to reach out to me too directly, I've got a pretty detailed outline I can send out. But we're really looking at, the work of peers, I think from the general, to the specific as far as principles and values and how we are really, meeting people where they are, really respecting the choices that they're wanting to make, how we show up being strength-based and so on. But then I really feel like we kind of designed it in a way that we're following the journey of the participant, who is pregnant and or parenting. So we're talking about the specific considerations related to pregnancy. We're talking about medication for opioid use disorder for people who have opioid use disorder, why it's recommended, and for the purpose of, one, for peers absolutely supporting folks, but supporting folks who are going to have likely difficulty in their own experience of being on medication while they're pregnant, So there's the whole emotional component of that and so on. What are the things that peers, we want to make sure that folks, particularly in a lot of ways folks with opioid use disorder, are they prepared for the possibility that their baby may have neonatal opioid withdrawal syndrome? Are they prepared and have what they need to be a part of their baby's care team? Should the baby experience that or need an extended stay, are they prepared for and have the support necessary to be in a healthcare setting where you will encounter, because you encounter so many people, you will encounter stigma that's going to make it hard for you to walk through that door to continue to show up for your baby, How do we help parents through all of those pieces? So there's also a pretty big component about why our earliest relationships in our lives matter for us as human beings and will matter throughout our lives, and how do we support parents in establishing those early relationships. So what I'll say is, and one of the things that folks don't get to hear a lot, is that when we look at substance use disorder as a disease and the neurobiology, that as parents increase their investment in their baby, it can help to reset the reward system. And what we do on the substance use disorder side is we teach people through psychoeducational approach, around parenting. And so we really want to shift and increase the investment in the value and the skill building around how to help support and strengthen the parent-child relationship. We do some pieces around recovery planning and some skill building and tools for folks around working on helping folks grow their recovery capital in a way that they want to. So, and there's a bunch of other things, but that would just take longer than I've already taken.
Thanks, Sharon. Next question, yes?
Quick question. Thanks. Tracy Van Black, Missouri Family Health Council. Laura, I'm just curious about the dissemination of the survey you mentioned, because it seems like you have a lot of robust data. And I just kind of wondered how you distributed that.
Yeah, so we've been doing presentations on the pointing times throughout the 2 years. But, we started, it's all evaluation that we did at NHRC. So we have been doing presentations, within the state. We've done presentations in some, research what I would call research circles. We're waiting for PID 4, which is in collaboration with RTI International, where we're deepening the work of the survey. So the survey always had the same demographics. And it's important that you're asking me because we've been tracking things other people don't track. For example, Latinx population, we went deeper to define the population. I know that yesterday we were talking with Guillermo about the fact that, in California, if you're not doing a deeper analysis of the Latino communities, which are so diverse, it doesn't make any sense. We've been tracking, for example, how much SSPs are serving native communities. And we saw the shift of SSPs really building relationships. So we saw, for example, our PID surveys have 11% participants who are Native Americans, which is amazing in SSP context. So the demographics is very important, and house status. We changed it to be the definition of homelessness under HUD. 70% of our folks in SSP who are participants are in house meeting the definition of homelessness. So why this data is important, we've been sharing that overall data. But the last one is a deeper dive on the smoking and fentanyl. We're looking for, because we're partnering with RTI, our partners who also can do much bigger dissemination. So we're looking for PID 4 to be defining what we're seeing in the field, overdose experiences, fentanyl smoking, the shift, how the market is changing, people primarily procuring fentanyl versus heroin, which is still distinct in California, which may not be true in other states. So we're also seeing that we still see a very boring drug and stable supply in California, but that's what we're doing. And so we have been disseminating, more than willing to share infographics that we've done throughout the different iterations. So we also have participated in the data from the National Overdose Prevention Network. We did a presentation. So Luca Bear, who is our evaluator, did a presentation on the PIDs because people are very interested. Because for SSPs, for those of you who don't work in SSPs, it's very hard to collect data. But if you do it point in time, we did it twice a year. We did it an exercise. We pay participants for their participation, so participants were paid. We were able to collect incredible data that might take about 30 minutes, so not the crazy. I know that there was almost a revolution. University of Washington had a gathering where the SSP says, we're leaving this gathering if you ask us to do a lot of data. So it's also managing, how do we train data evaluation for SSPs, which has been incredible because some of our SSPs, as you were mentioning, were doing transactional work, and through the PID surveys, they started engaging in conversations. So it was a way to really start having conversations with participants, which have been an incredible impact for the programs itself. To say, we had the first iteration conversations about some qualitative. Why wouldn't you take methadone, or what about treatment programs? And people will tell us with deep detail how much stigma and failure they felt every time they went to an NAAA meeting. They also describe with some providers or methadone. I don't have to explain. Methadone is still, DEA regulated and is a punishment system. So, the fact that we're going to do take-homes is amazing. But PID service can be that incredible gem of having conversations with participants that otherwise we don't have. And so we will be disseminating PID 4 probably more broadly, but you can reach me at guzman@harmreduction.org. I'm more than happy to share the survey, sort of like the sample survey, but also the infographics that we collected.
Thank you, Laura. I think we have time for one more question. But we will also gladly take that time back. And so that's great. So please join me in a round of applause for our panelists.
I'm back, so you know what that means. It's another Ignite talk. It was so good yesterday, we decided to do it again. So just a quick recap, if you missed it yesterday, the Ignite talks are really meant to ignite discussion. So they're gonna be short, creative presentations that require a lot of talent, and we've got a lot of talented folks up here today. So again, join me in a round of preemptive applause for all the hard work that they've put into that. So again, just as a recap, Each presenter will have 5 minutes. They will be presenting 20 slides that self-advance, so that's 15 seconds per slide. They do not control those slides, so they really have to do a lot of work to make sure that they stay on time and task. It's a huge effort, and I really respect all the presenters we have here today, so thank you again. So without further ado, I'd like to introduce our presenters for this round of Ignite Talks, which are gonna focus on local and community-based syndemic approaches. So first off, from KC Care Health Center here in Kansas City, we have Morgan Brinker and Paisley Williams doing a tag team Ignite. Excited to see that. And they'll be talking about syndemic services at FQHCs. Next up, we'll have Carl Highshaw from the Ahmad Institute in LA, and he'll be talking about some work that his organization has been doing related to the Minority AIDS Initiative. So thank you, Carl. And last but certainly not least, we'll have Patrick Stonehouse from the Chicago Department of Public Health, and he'll be talking about the Syndemic Infectious Disease Bureau that's been recently established there. Just as a reminder that after all the presenters have finished their presentation, they'll all be going to each of the 3 breakout rooms that are listed here, and you'll have the opportunity to hear more about the work that they're doing for 20 minutes in those breakout rooms. And we'll be sure to put the table that's here up afterwards so that you'll know which breakout to go to depending on which presenter you'd like to go see. So without further ado, I'm just gonna pass the baton over to the folks from KC Care to get us started.
All right, we're ready to go, everybody. That's what I have to say to get the slides started. So I'm Morgan Brinker. I'm the Harm Reduction Coordinator at KC Care Health Center. We are a federally qualified health center. We have primary care, oral health, mental health, insurance navigation, and case management services for people living with HIV. So I run our SSP here at KC Care. We've been around since 1993. I'm very jealous of both Oklahoma and California because we are not legal and we definitely don't have millions of dollars. So we are operating under a legal gray area. If you've heard Laura from NASDAD talk about it, she does it perfectly. So there's no law in Missouri that says that we can't be here, but there's no law that says that we can. So we are just hanging out and getting private funds. So we can't accept any federal, any state money. So we are located in the garage. That's why it looks the way it does. You're seeing pictures of our actual exchange. So that is what you're seeing, the chute. That's where we collect used syringes. We can collect anything they drop off. We're gonna give them, we're gonna match them up to 500 syringes, and then we can always give 30 if they come in with nothing. We have the works, our menus right there. We have safe smoking and safe snorting supplies. That's newer as of December. We have IM and nasal Narcan, fentanyl test strips, which were just legalized in Missouri as of July 10th of this year. So Senate Bill 45 did that for us. Yes, very exciting. And that's our wall of volunteers. So I'm the only paid staff at KC Care that can operate Exchange. The rest are wonderful, wonderful people who are donating their time. That's one of them, that's Naomi. So we're very lucky to be here, and thank you for letting me talk about it. And then Paisley will talk about our other pillars. So there's 4: Exchange, CATS, our free testing services, PrEP, and outreach. And we'll get into that right now.
Good morning. Casey Care, Paisley Williams. I'm the prevention manager. So this is our testing and counseling room that is actually in Casey Care in our newest location. So in this CATS room, we test for gonorrhea, chlamydia, HIV. We have the 20-minute test. We have the 1-minute test, which is also INSTI, finger pricks only, and we also do syphilis, which will be a blood draw. So in our CATS room, we provide different condoms, what you see hanging that was in pink and black, actual like Laurel panties, that is also dental dam. This is Morgan. She's actually testing the client. So we want to make sure that we are following safety protocol with protection of the staff and also the client. Another pillar of the prevention department is outreach. So here is a fun Halloween outreach table that one of our staff members are doing. We always want to make sure that we are catering the event and our trinkets around what the participants are wanting. So outside, we are also doing another outreach event. So engaging, we always want to make sure we are engaging with the patrons, providing some type of interactive activity for them to talk about sexual health or anything else that we may have on our table. Another outreach event that actually has a spin wheel now. So kind of switching it up. This looks like this may be around Pride. So, you know, a lot of things on the table, but it definitely draws in patrons to engage with us. So for this outreach event, this was this year for Juneteenth, we did something a little different this time. We noticed that we are needing more of the community feedback of what they want to see. So we did 3 collective surveys of, you know, how do you plan to influence your actual community with your health, and also what activities you want to see. So with that data that we still have now, something real simple, a simple survey, those responses are going to be driving our future outreach events to actually do more whole person instead of just sexual health at our tables. So another outreach event at the actual Kansas City Health Department, we did Narcan demonstrations and also handed out Narcan there. So for our first time at the Black Greek Picnic, we utilized our mobile testing van. We tested on the inside, same test, probably with the exception of gonorrhea and chlamydia. And these slides are moving so fast, it breaks your train of thought. We used it for the first time in our Black Greek Picnic. Another outreach event, so we actually got the participants involved. Looked like this young lady is actually learning how to put on an internal condom. We know internal condoms are for men and women now. Another pillar for prevention is PrEP. So we help clients with the Ready Set program, and we also help them with the Gilead Payment Assistance program. We follow up with them 1 week, 1 month, 3 months only. And here is the prevention team that is at Casey Care. It's a total of 7 of us. Thank you.
I am ready to go. My name's Carl Highshaw from the Ahmad Institute. I could not do this without notes here. I think we're going to pull it up. There we go. So initially, the Ahmad Institute was founded as a grassroots integrated peer-based health and wellness organization. And we unapologetically prioritize people in a way that is culturally relevant to people who are Black and identify as LGBTQ. And we focus on people who are disproportionately impacted through systematic inequities. We do that in a way that is unapologetic because we think it's important. Initially, our activities were solely focused on community and social gatherings. As a community network, we had a common bond amongst us in that each of us identified or had loved ones who were in recovery from substance use disorder, who were impacted by HIV or AIDS, and who had been affected by the criminal legal system. Ahmad eventually formally became a nonprofit entity and received its first federal funding through the SAMHSA Targeted Capacity Expansion Peer-to-Peer Grant in 2014. We began to focus on 3 very specific goals. SAMHSA really introduced the concept of harm reduction to our network, and which was really a big thing for us because many within our network really came from a traditional 12 steps on an abstinence-only or sobriety point of view. So we worked really hard to work with our peer ambassadors to expand our understanding of behavioral modification strategies because the concept of harm reduction really challenged the core belief for many of them. We had to work really hard to develop a many pathways approach. So soon we expanded to have our efforts expanded through the Minority AIDS Initiative as a grantee, providing HIV prevention, navigation, and support services that were connected. I'm going really fast here. The Ahmad's effort that is probably the most important and close to my heart is our Reclaiming Innocence project. In reality, Black LGBTQ people are especially targeted, and we know that contact with the criminal legal system is a risk factor, and our solutions must factor that as a reality. And notice I did say criminal legal system, I did not say criminal justice system, because justice is merely a myth within the system. We have really been working with the LA Mayor's Office, the California Board of State Community Corrections to provide reentry to those being released from incarceration. We do housing support, therapy, employment training, and peer community connections. I mean, in Los Angeles, we really do have a major housing crisis happening right now. And in 2019, we became a SAMHSA GHBI grantee. That's the grant for the benefit of the homelessness. So we expanded our interim housing support that prioritizes those in a way that, again, is culturally relevant to people who identify at the intersection of Black and LGBTQ, because there's so few options. Project ROAR is our restoration, outreach, and opportunities project that really focus on diverting young people from the criminal justice system so that they don't end up in the criminal pipeline. We really work really hard to really have this broad recovery concept with regards to the work in which that we do. We have a peer-based staff. We often say that lived experience is just as valuable as educational experience. Our board of directors started to especially pay attention to our pay scale and made a purposeful effort to raise our minimum wage for frontline workers to $25 an hour for all people. How can you do your work for people in the community and not be able to provide for yourself? So it's important. Our client segment, especially a house-involved community, is a big part of the work in which we do. I know that I'm speaking to the choir with regards to the importance of having this integrated community approach to the work in which we do. It's important to our work at the Ahmad Institute. I think my next slide is our logic model. It goes on, blah, 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 15 seconds to read all of that. It's all really good stuff. But the important thing, I think, is that Ahmad really focuses on community building. It's an important part of what we do as an organization. I encourage you all to look us up at ahmad.org or follow us on social media, Ahmad Institute. I'm never really good at social media and any of that. Ahmad Institute, Ahmad_Institute is what my folks would say. Look us up, follow us, tweet us, do all of that good stuff. Thank you.
I just asked if it was fun, because it does feel kind of like a game show. Okay, let's go. So, my name is Patrick Stonehouse. I use he, him, his pronouns, but anything with respect is fine, and I'm the Director of Program Operations for the Chicago Department of Public Health Syndemic Infectious Diseases Bureau Community Health Services Branch. And I had time. So this is Chicago's Syndemic Infectious Diseases Bureau. We cover, when we initially designed it, we were focusing on HIV, sexually transmitted infections, which were already co-located in the previous iteration of the Bureau, the HIV-STI Bureau. So we wanted to add in viral hepatitis and tuberculosis, and then Mpox came on and it was just a thing. And it was all based on, we look at the data because the data we use to make the arguments, but we already knew the case. When we presented the data, it was like, well, yeah, we get that. There were still issues that people had that were largely based on like fiefdoms and territoriality of the different areas of work that we did. But this is how we got. This is where we are now. So Syndemic Infectious Diseases Bureau, Community Health Services Division, which I'll talk about, Public Health Services, I'll talk about a little bit. In total, 140 FTE. Most of it still resides within the HIV-STI side of things, and that's important for us to keep. So Public Health Services Division is stuff that we are uniquely authorized or positioned to do, so our HIV surveillance, data coming in, public health interventions, partner services, case investigation and such. We leveraged that to be able to start doing case investigation and surveillance work for viral hepatitis and for Mpox, and that's part of that integrated structure. I'm gonna talk more about the Community Health Services Division in a minute, because that's mine and I love it. STI clinical care, so there are 3 STI clinical services, clinical sites that do STI screening, HIV screening, HCV screening, started doing Mpox screening and vaccinations as well, so really bringing all that together. The TB is, it's directly observed therapy, and for us, it's largely like, we're still figuring out how to fully integrate that part of it, like get this to work together, but in the end, the last slide will actually show where we are with it now. Strategy, finance and administration, pretty straightforward. This is one of the biggest things that scared the heck out of people when they started thinking about integrating with HIV-STI, because that big gray thing is the funding that we get for HIV, right? And if you're viral hepatitis and you get $315,000 a year and you're coming into that, you're looking like you're gonna get swallowed, right? Because that's what Pac-Man did in that picture. But we needed to make sure that we weren't doing that, and instead we were sort of doing it in a way that was like, We're the mama bird with partially digested worm, and the baby's coming in. That's how we framed it. Healthy Chicago 2025 is this overarching city effort to reduce the life expectancy gap between Black and white Chicagoans, which currently is 10 years. And this particular section is looking at the root causes of the inequities and how we see those impacting our syndemic infectious disease. In HIV services, we had created a status neutral approach. This took like 2.5 years of community engagement. And by community, I mean not delegate agencies, not like known stakeholders, but like going out and talking to folks whom we had never talked to before to create that structure. Integrated structure in community health services. We have healthcare access, which is direct services, clinical and supportive, housing and resource coordination. We have housing for persons on PrEP, as well as persons with HIV. Community development is all about structural and systemic population-specific by, of, and for interventions. And this is our planning setup. We have our Chicagoland Syndemic Advisory Council, which is our formal planning council. We also have all these other spaces that are more or less formal that allows for us to get input from folks about whatever it is that they want to talk about. And we very intentionally create spaces where folks talk about what they want to talk about and guide us on what they think needs to be done because they're right. And it's important to remember syndemic is disease states, but it's also people, and I mean community members, but also staff, like really getting to know the people who had been doing tuberculosis and the people who had been doing viral hepatitis work at CDPH and why they were freaked out by joining us. This is some syndemic marketing we put together. So this is all about MPOX. This was all community generated, but you could replace Vax with PrEP and it would still work. And it's important to remember that this is all still we're working on it. We're figuring stuff out. And part of it is coming to conferences like this and hearing from other people about what it can look like when we keep working on it. Challenges, of course, dollars, like the slide I showed with the Pac-Man, like all the money in one place. The money gives directives, the money gives obligations. It doesn't allow the flexibility that you would want to be able to do the whatever as directed by your community members and partners. HIV is the bull in the china shop. We try not to be, but for real, we are. And lastly, the whole core, this is a picture of Thelonious Monk and his band doing an improvisational practice. It's about a bunch of genius people getting together and listening to one another and creating space for one another and stepping up when it's appropriate and stepping back when it's appropriate, and that's what we try to do. Thank you.